Hi, it's Dr. Centeno, and I'm going to give a lecture here that I just gave down in the Bahamas at the Regenera Global Conference, Regenerative Medicine 2.0, Redefining the Practice. And it was a very cool conference in that it had a lot of folks from Florida as well as Latin America. So I really got a chance to meet a lot of our Latin colleagues who are performing these procedures. And the title of the lecture is The Good, the Bad, and the Ugly. And I really went over, some of the good, the bad, and the ugly in stem cells today. My disclosures: I'm the CEO of Regenix, which is a large U.S. medical group practice focused on regenerative interventional orthopedics. And my background: began using stem cells to treat orthopedic conditions in 2005. Was really the first person in the U.S. to do that kind of work. And if you include certain applications like cultured stem cells for discs, etc., we've had many, many firsts in the world as far as treating various orthopedic conditions. I've published 16 peer-reviewed publications on the use of stem cells to treat orthopedic conditions. We have university-style stem cell research lab as part of our Colorado practice, which is very, very unique. We have all the toys, and some of them you wouldn't see in a university research lab for stem cells or cell biology. And we're tracking about 4,500 now stem cell treated patients in a nonprofit registry. So way back in 2005, we started doing this work. We were the first people or the first doctors at that time using stem cells in the U.S. to treat orthopedic conditions. And since then, I've seen quite a bit change. In 2009, I started ICMS to attempt to create guidelines. And about that time, we saw the first physicians outside of our clinic, meaning other doctors, start to do this kind of work. And about the same time, we saw physicians begin to use adipose stem cells. And then around 2014 or so, we really saw physician use of stem cells explode. And in that time, I've seen the good, the bad, and the ugly happen. So over the last 11 years, I've seen some really promising stuff, some not so good stuff, and some truly awful things with regard to stem cells and how they're being portrayed to the public. So let's start with the good. It's important to understand that what we do at Centeno Clinic is very, very different. It's interventional orthopedics. What does that mean? We have simple injections, we have surgery, and we have interventional orthopedics, which is really in the middle of those two things. What interventional orthopedics is not is simple injections. About 95% of U.S. physicians can do very simple injections. Those are folks that advertise that they do any kind of orthopedic stem cell work. They can inject inside a joint and do a simple intra-articular or inside the joint injection. But what they really can't do is anything more advanced. And as I'm going to show you, there's quite a bit that's more advanced. About half of those doctors will do those types of injections blind. About half of those doctors will actually use guidance. And then we have a handful of physicians that are doing a few more things, let's say inside a knee, rather than just getting the stem cells inside the joint. They may be placing the cells under ultrasound into the meniscus. And then there's interventional orthopedics, which is about 1% of U.S. physicians are doing this higher level work. And what is that higher level work? It's injecting under guidance cells into lots of different areas. So in the hip, it's not just inside the joint. It might be in the labrum to prevent someone from getting a hip labral surgery, or into the various tendons that may have problems or tears, or into the bone of the hip if there's osteonecrosis or the iliotibial band. In the knee, it's more than just injecting inside the joint. The cells might need to go into the femur bone, into the ACL ligament, the PCL ligament to help prevent, let's say, an ACL surgery, or into the MCL ligament to prevent an MCL surgery, or into the patellar tendon, or into various other tendons, or the patellofemoral joint, or the meniscus, et cetera, et cetera. Lots of different places where cells can go where patients might have problems. In the shoulder, it might be any one of a number of different areas. Let's say a superior labral tear that might require surgery, and under precise guidance, those cells can be placed at that spot. So that's what we do, interventional orthopedics, which is quite different from simple joint injections. Now, one of the things that's been really good over the last number of years, at least in bone marrow stem cell research, we've seen an incredible number of patients who have had their results published in the peer-reviewed medical literature. So what I'm showing there is each one of those little circles is a different study that's been performed. And if you zoom in on those, you'll see that each one of them actually on the document that I put on the website has a link that goes out to the PubMed article. And when I add up all of those different patients, meaning the N of each one of those studies, what's interesting is that 8,207 patients have had their results published in the peer-reviewed literature to date. That's a lot of patients. And we're proud to say that more than half of those patients are our patients. So we've produced a lot of this research, but we're not the only ones out there. There are lots of others who are assisting in this area. So this is really great. This is the good. What I'd like to focus on in this good section are guidelines for high quality stem cell care. And I break that down into 5 simple things that patients should be able to expect. And regrettably, they're usually not getting these things. The first is candidacy grading. I'll talk about that. Expert treatment is another. If there's investigational care being used, meaning a new use of stem cells, at least an animal model should show promise before we stick these in patients. There should be data collection via a registry for every treated patient, and there should be publication of that data. So candidacy grading would seem pretty simple. Pretty much every medical procedure ever devised has a candidacy associated with it. Either the patient's a good candidate, a fair candidate, or a poor candidate. The problem in stem cells is that that doesn't happen. Everyone's a candidate who's got a credit card that works, which is ridiculous, absolutely insane. We candidacy grade our patients, and everyone should as well. You should be able to look a patient in the eye and say, you know what, you're a poor candidate for this procedure. I don't see any downside to you trying it, but I think it's unlikely to work. And this should be based on data that's being collected where that's possible. So for instance, we know that severe hip arthritis for same-day stem cell treatments would make someone a poor candidate. We know that patients are poor candidates based on other things that we found. Again, no medical procedure ever invented has anything approaching or close to 100% success rate. Expert treatment. It would seem obvious that if you're going to spend a lot of money on a stem cell procedure, your doctor had better be an expert in the area that's being treated. You don't want your plastic surgeon who knows how to inject Botox into your face, injecting your knees. You don't want a family doctor treating a complex neurologic condition that he knows little about. You don't want a burnt out ER doctor treating complex cardiac diseases either. So you should expect that your doctor is an expert in the area he's treating. And stem cells are not magic pixie dust to be wielded by physicians who have no expertise or advanced knowledge of what they're treating. So specialists in specific areas must remain in the fields that they know and that they understand. In addition, if you're going to get a new use of stem cells, you really need to expect that there needs to be an animal model that shows promising results using that specific stem cell type. As I'll show you, Many times in fat stem cells, otherwise known as stromovascular fraction or SVF, this isn't happening. We're seeing fat stem cells being offered for all sorts of things that we don't have any idea using animal modeling that fat stem cells would be helpful for, which is inappropriate. We also need data collection via registry for every single treated patient. So what that means is tracking patients usually at 1 month, 3 months, 6 months, and every single year after treatment. And a registry is not a phone call to the patient after the treatment or giving them a form to fill out after treatment. It's pinging them at set time points to see how the procedure went. It's using validated outcome metrics to make sure that what we're seeing is a real effect. And you need to have a really big team set up to do this correctly. Not only do you need to have an electronic system of pinging patients, you also need to have live people calling the patients that don't respond or bugging patients when they're in the clinic to fill out their forms. We also need to see transparent reporting of that data, which we rarely see right now online. What do I mean by that? All data, not just cherry-picked data, needs to be reported online or explained why it was excluded and what was excluded. We do this every year from our 35 sites, and it takes a lot of time, energy, and effort, but it's well worth it. In addition, peer-reviewed publication of data should occur. What does that mean? Peer-reviewed publication is you put out a case report when you've only done 1 or 2 of these. That can go to a case series or comparison trials, which eventually lead to randomized controlled trials. I've often heard physicians say, you know what, I'm not a researcher. Then you shouldn't be offering investigational care. I don't have the money. Case reports and case series and comparison trials are really cheap. So what happens when guidelines aren't enforced and when physicians don't enforce their own guidelines? Someone steps in to do it. Whether that's the FDA, state medical boards, already the Florida and Oregon medical boards have acted to remove licenses of physicians who were doing inappropriate things with stem cells. The civil court system also loves to step in, meaning malpractice, and that's already happened. What's really fascinating is we see attorneys out there advertising for stem cell malpractice. As crazy as that sounds, there's at least 3 or 4 that are beginning to advertise for this stuff. So let's go over some really good things that have happened. And we kind of laid down some rules. Number 1 is we've had a bunch of information showing that these procedures are safe. So the 3 main studies, 2 of these are ours, and one of them was published by Hernegal. There's a 339 patient study that we published in 2011 on cultured stem cells showing good safety. There's an 1,800 patient study published by Hernegal that only looked at cancer and tumors. So I didn't look at all safety, but it certainly said that there weren't any tumors or cancer increased rates that were happening because of stem cells. Then there's our largest paper ever published, I believe, in stem cells for any application, 2,372 same-day bone marrow concentrated and culture expanded stem cells. Our paper looked at all complications and showed good safety. Some interesting things from the orthopedic world that are really good. Stem cells may be able to help rotator cuff healing. This is a really interesting study published by Felipe Hernegal, not a big study, but it looked at 45 patients who had had rotator cuff repair, and the patients who actually had rotator cuff repair when they injected stem cells after the surgery or at the time of surgery, they saw a dramatically better re-tear rate. So basically the re-tear rate was halved in the patients that got stem cells. This is some of our early data from our randomized controlled trial. This is no surgery for rotator cuff tears. This is just precisely injecting stem cells into the rotator cuff tears. And as you can see here, between the group that got exercise versus the group that got stem cells, the function is going in the right direction. The pain score is going in the right direction. So function is improving, and their pain is improving dramatically over just the exercise group. Stem cells are likely to help knee osteoarthritis. There are a number of different studies that have been published. Ours is the largest prospective case series at 840 patients, but there are others as well. A study published by Van Ness on 55 patients. This was a double-blinded randomized controlled trial using allogeneic cultured cells, which showed good efficacy for pain and function in knee arthritis. There have been two other small RCTs published showing similar things. So we have here at least some good early evidence that stem cells can help knee arthritis. On hip arthritis, ours is the largest prospective case series published at 196 patients. That was published a while back, and we now have many more hip patients, about 400 or so. But as you can see there, we've got a large study. There's a smaller prospective case series out there. Bottom line is that hips don't respond as well as knees. More severe hips are generally unresponsive or minimally responsive to a same-day stem cell injection. They tend to do better in our experience with cultured cells, but some promising results in mild and moderate hip arthritis. How about lumbar degenerative disc disease? We have a bunch of different small studies out there that seem to show that injecting stem cells into the disc can help. Lots of different types of cells used here. Patine had a prospective case series where he published 1 year and 2 year data. It's a small study, but it showed some promising information on treating patients with disc pain. Stem cells for ACL tears. We've published the only work that's been published on this to date. We basically used pre and post blinded grading of imaging. And what we generally saw was significant improvements in ACL signal after we precisely placed stem cells into the ACL. A very, very different approach than just blindly injecting into the knee, which doesn't work for this. But we were precisely placing stem cells in the ACL. We have a second paper that's coming out soon that'll expand this to about 35 patients with MRIs. So very, very promising stuff. And in this case, really seeing some home run results. So now let's talk about the bad. What's going on out there? Well, one of the problems you have to always look for when review studies in stem cells is the concept of putting your finger on the scale. We see there a Saturday Evening Post illustration that shows the guy weighing the chicken and putting his finger on the scale to get what he wants, a little higher price, a little extra weight. And researchers can do that as well. So we have to be careful of this. So as one example, there was a study published last year that showed amazing results with adipose stem cells for peripheral, for basically knee arthritis and hip arthritis. It was published in January of last year, and it was a large study, 1,856 hip and knee joints treated with adipose fat grafts and stromal vascular fraction. Both stem cells that were isolated and just a fat graft. And what was amazing was that 91% of the patients had greater than 50% improvement at 1 year after the injection, which is pretty amazing. Those results are really just off the charts. I haven't seen anything even close to these results being published by anyone else for any other indication, whether it's cultured cells, cultured fat cells, cultured bone marrow cells, same-day fat cells, same-day bone marrow cells. Thing to watch here, however, was that 3 of the 5 metrics used to determine outcome were determined by the physician. Now that's a problem because it should only be the patient that decides the outcome. The patient that says this worked or this didn't work, if we allow the physician's say in this whole equation, then that causes problems because ultimately all physicians want their patients to get better, and we are dramatically biasing the results in our favor. So all metrics that we use to track patients should be either patient-reported or objective. They should not rely on the physician at all. Well, let's look at the whole bone marrow versus adipose or fat debate. This is a huge, interesting debate that has had its own not so pretty little white lies told. So how do these two tissues compare when it comes to stem cell content, or MSC or mesenchymal stem cell content? Now, there are many claims that adipose tissue contains many more stem cells than bone marrow. Is this true or false, or is this just one big urban myth? You know, I've seen claims of 500 times more, 1,000 times more, 2,000 times more. Really interesting stuff. And to find out, it's really all about the math. This is one of my favorite movie clips of all time in this movie called The Red Planet with Val Kilmer. Let me play it.
I think we're somewhere downrange.
Calculating landing ellipse.
Based on our last uncorrupted nav state, I'd say we're somewhere in this 60 by 120 kilometer ellipse.
All the mission data is in here. We just got to close in on the downrange variables. It's about the math.
This is it. That moment they told us about in high school where one day algebra would save our lives.
So this is it. This is the moment they told you about in high school where algebra is going to save your life, or at least tell you how to determine fact from fiction. So let's do the math here. Stem cell counts in both bone marrow and fat are reported as a percentage of total nucleated cells in the tissue, meaning the total cells that are present in the tissue. Initially, that comparison seems to dramatically favor fat. Flow cytometry studies show that stem cells represent 1 to 5% of the total nucleated cells in fat versus only 0.01 to 0.5% in bone marrow. So that's a pretty huge difference. So that's where those numbers come from. The problem is that the denominator, the number of total nucleated cells in each tissue, is quite different. So it is all about the math, the 5th grade math. There's a huge difference in the number of nucleated cells in bone marrow versus fat. In fact, there's 100 times more in bone marrow than in fat. So if you compare versus the number of nucleated cells, that's an invalid comparison because it's 100 times more for one tissue than the other. So adipose really doesn't have 500 to 2,000 times more stem cells. In addition to that, if you look at things like hematopoietic stem cells for orthopedic purposes that would be fantastic to use in muscle repair, for instance, bone marrow has 1 to 2% of nucleated cells, whereas fat has an extremely small number. And once we divide by 100, we get an extremely smaller number. In addition, we also see that these stem cells for different applications work differently. So in the case of creating cartilage, we have a number of different studies that show that bone marrow is superior to fat. In fact, you really have to push fat stem cells very, very hard to turn into cartilage. So again, this claim that there's all of these stem cells in fat versus bone marrow is really not accurate. It's not ugly, but it's certainly not good. So it's in the bad category. Here's another one. Because fat stem cell procedures where the stem cells are isolated from the fat are increasingly being outlawed in the United States, a lot of doctors have turned to fat grafts. So they're starting to do fat grafts to try to see if they can get around that, because a fat graft is allowed, whereas digesting the fat to get the stem cells is not allowed. Well, in 2012, we tried this. We actually used a little mechanical device that seemed to really mechanically emulsify the fat. The concept was that it would chop it up so finely that the stem cells would come out. So we tried to do this, and we centrifuged it, and we got even what looked like maybe even a small pellet at the bottom. But we got no viable stem cells either through flow cytometry nor culture. So this little mechanical emulsifier that a lot of doctors claim creates stem cells from the fat wasn't doing that. In 2014, we used a sophisticated vibration-assisted lipo-suction machine, and the folks that made the machine claimed that just the vibration in their system, as you were taking the fat out with this device for liposuction, isolated the stem cells. Now, we test everything at our expense. We don't take any money from any manufacturers. So we tested this at our expense to see if this was true. And we got very few viable stem cells via flow cytometry and culture, and much, much less than would be in a bone marrow concentrate procedure. Again, not really getting us there. How about the new generation of fat processing systems? There's a bunch of them out there. Well, what's really fascinating is you really need to read the fine print in these studies. One of our ex-fellows came up to me, and I would think he would have known better, and showed me a research paper that seemed to say that this one system got a lot of stem cells out. And I had to show him that, yes, that was true. Once you digested the sample with collagenase, which would make it an illegal U.S. procedure. So again, this machine really wasn't producing much in the way of viable stem cells. And most physicians, however, that would read this information wouldn't know that. So in the end, I guess clinically all that matters is whether or not there's something to using a fat graft in a joint, right? Because it doesn't really matter if there's any stem cells in it. If you inject it in a joint that works, then that's great. Well, there are a lot of physicians that use bone marrow plus fat grafts, and we tested this. We're the only people that have ever tested and published our results. And the bottom line was our registry data did not show that adding fat made any substantial difference to just using bone marrow concentrate alone. Well, here's a really fascinating one. And I call this the treating everything phenomenon. This seems to happen more with fat-based stromal vascular fraction clinics where they literally offer to treat pretty much every known disease. And they'll frequently do what I call the research bait and switch. So let me tell you what that is. So I looked at one very popular U.S. stromal vascular fraction website, Fat Stem Cell Clinic website. And they listed extensive research on the website to support that these fat stem cell treatments would help degenerative disc disease, chronic obstructive pulmonary disease or emphysema, COPD, congestive heart failure, ALS, stroke, spinal cord injuries, rheumatoid arthritis, orthopedic problems like arthritis, kidney disease, multiple sclerosis, diabetes, Parkinson's disease, macular degeneration, and traumatic brain injury. Yikes, that's a long list. That sounds like either too good to be true or that this is magic pixie dust. The clinic listed 54 different studies to support each one of those, meaning not 54 per, 54 for all of them. A whopping 94% of the research listed was not conducted using fat-derived same-day stem cells that the clinic used. Instead, most of it was culture-isolated and expanded bone marrow stem cells, and most of it was animal models, but it was interesting that it was a bait and switch. A very different stem cell type was used than what the clinic was advertising. So how much research on SVF, meaning fat stem cells, was there supporting these indications when I actually looked for myself to try to see what had been published? Not much. Here's the graph that I came up with. For traumatic brain injury, there was not even minimal scientific evidence that stromal fraction would work. For spinal cord injury, same thing. For multiple sclerosis, there was no animal data, but one 3-patient case series. For rheumatoid arthritis, there was nothing. For orthopedic indications, there were some things published. But one of those was that study I just talked to you about, that basically where the researchers had their finger on the scale. For Parkinson's disease, there was nothing published. For degenerative disc disease, there was one goat model that showed that it didn't work, and one medical misadventure showing a serious patient complication. So there was no evidence that degenerative disc disease would be helped by injecting stromal vascular fraction or fat stem cells. For ALS, there was one mouse model and no patient data. For scleroderma, there was a few small case series. There was no information for diabetes, no studies for kidney disease, no studies for COPD, no studies for congestive heart failure, no studies for stroke, and no studies for macular degeneration. So let's now talk about the ugly, meaning the really nasty stuff that's out there. And probably the most bizarre phenomenon out there is amniotic stem cells, or also called fetal stem cells or placental stem cells. And this has been spreading like wildfire because we have countless orthopedic sales reps who are hawking this stuff to doctors as rich in stem cells. And this is from one amniotic stem cell website. The stem cells we use at whatever center this is coming from are harvested from basically a pregnant mother scheduled for a C-section and processed in an FDA-approved lab. Here's an interesting statement. The amniotic stem cells are neutral cells that do not contain any DNA. Now, the big problem with that statement, obviously, is all cells that do anything contain DNA. So obviously the person that wrote this didn't have a clue about even basic cell biology, but we'll forget that little omission for a moment. Because they are neutral, a patient cannot have a rejection or reaction to them. The funny thing about that statement is one of the things that I have heard from doctors that are using this stuff is that you can get a robust patient reaction from them, meaning a robust, very serious inflammatory response because the body detects this as foreign tissue. They're completely safe to use. In fact, there's not been one adverse side effect ever documented since 2007. Well, that's correct in that there's absolutely no research published showing that this stuff is safe at all to be used for what it's being used for, meaning orthopedic indications. And basically saying that since it has stem cells, any parts of the knee which are damaged can potentially be healed, which based on what we know about stem cells is absolutely not true. So what's going on with this stuff? It's basically sold under a 361 FDA tissue registration, and it contains no viable stem cells whatsoever. The FDA registrations state that it contains no viable stem cells. The Interventional Orthopedics Foundation, a 501c3 nonprofit, tested many products and all had no viable cells. Not even a viable stem cell. We're talking about no viable cells at all. They were further tested to see if they might help mesenchymal stem cells from older patients. They didn't. And they do contain growth factors, so we don't know whether this works. There's really not much research. You have to be incredibly careful about just reading and interpreting the white papers put out by these companies because they are incredibly deceiving. So check this out. What's really interesting about this is there's only about 1.5% of the total cells in living or fresh amniotic fluid that are stem cells. So here, a doctor reads this marketing material put out by a company called Surforce, and they read that the total cell concentrations of these three products, the Surforce and the two competitors, are very high. And then they read that there's an awful lot of viable cells in Surforce, and what they don't first understand is that only 1.5% of those would actually be stem cells. They believe that there's really 2 million stem cells. And I've heard doctors tell patients this. They don't understand that there aren't 2 million stem cells, but the patients believe that. The doctors don't know enough to know the difference. But there's even something more fascinating here. What's really fascinating here is following what's happening with AmnioFix. So I'm going to show you that here in a second. What we have seen, obviously, is that when we look at these, if you just look at these, the data, the viability of this stuff is really poor at 62%, number one, if it's true. Our researchers has found that these products and these cells are so beat up that they aren't viable at all. And our data shows that cell fragments in amniotic tissue will exclude trypan blue. So these live dead counts that are performed with trypan blue are likely not accurate at all. We know based on our research that they're likely not accurate, meaning that they're measuring dead cells that happen to look like live cells. And there's a sure tell here. There's a tell here that shows you that these guys have not a clue what they're doing. And that's what's going on with AmnioFix. So let's look at this one right here. What's really important about that is AmnioFix is a gamma irradiated and dehydrated acellular product, meaning that they make no claims that there's any viable cells, and there can't be. They gamma irradiate the stuff to make sure that there's no viable cells, there's nothing living. In addition to that, they dehydrate it. They take all the fluid out. It's a powder. You can't reconstitute human cells that have been dehydrated. They die. So it's an acellular product. So you can tell right here that these guys don't have a clue about what they're talking about. They're claiming that AmnioFix has 1.3 million viable cells per ml. How did they get that number? Again, they did this simple trypan blue stain that seemed to show that there were 1.3 million cells. But since this type of tissue tends to exclude trypan blue, which is what a live cell does, they perform these measurements. And they never really thought to understand that they were measuring a dead tissue. So as soon as they got any viable cells in AmnioFix, they should have sounded these scientific alarms saying, oh my God, we've screwed something up here because there should be no viable cells in this tissue. So what are the amniotic conclusions? These may have growth factors, cytokines, extracellular matrix effects. The big question for me is whether they're any better than much less expensive PRP. Probably not. Some providers have reported success rates using these to fill gaps, and that's fine. But telling patients that this is a stem cell procedure or product is absolute full-on consumer fraud, do not pass go to jail type stuff. And yet we have at least 100 websites out there right now on the internet claiming that these doctors are offering stem cell procedures, which is, again, consumer fraud. So that's the ugly. So in conclusion from today, there's an awful lot of promise in stem cells. However, they aren't magic pixie dust, but they're being advertised as if they're magic pixie dust. And we need to enforce guidelines on ourselves or they will be enforced on us. So let's clean this area up. Let's do good work. Let's try to do some really interesting things to help patients with this new tool, not just hype the snot out of it so that we can get their credit cards to clear for the maximum amount of money. So thank you so much and have a wonderful day.